Good morning, everyone. So today we have a unique session for the postgraduates, that is the Meet the Examiners, in which there will be three presenters. They are presenting the cases of the different subspecialties. And we have a eminent examiners, Professor T.P. Lahane sir, Professor Rajesh sir, Professor Ragni Parikh ma'am. They are the examiners. So the basic idea behind this session is what an examiner think. So here is a one to just like a two interaction, means the questions is reversibly asked by the PGs, means our presenters. They will exactly ask the so here you will get the answers directly from the first presentation. Dr. Nilesh, you are going to present on which topic?
The first case will be of glaucoma, sir. And since we are starting for the first, all the other cases are going to be short. We are showing the picture and then presenting. So I thought the PGs might benefit to show how a glaucoma case history should also be presented during examination. This is a case which I presented during my residency when I was first year of diploma student. So I thought I will take that presentation and present it again. So the female patient presented with a loss of vision in left eye since 7 years and whitish discoloration of the black part of her left eye since last 6 months. The patient was apparently asymptomatic 7 years back that she noticed blurring of vision in her both eyes, which was sudden in onset, non-progressive and painless. It was associated with episodes of vomiting, giddiness, generalized weakness and pain in lower limb. She used spectacles lying around in home for symptomatic relief and was treated for other symptoms by family doctor. 2 days later, she had an episode of fall. She was unable to get up and then she was brought to the hospital. She was brought on the same day and she had LOC for 8 days and admitted in comatose state in ICU for the 8 days. During her stay in the ICU, as per her relative, she was evaluated by ophthalmologist and was started on some medications, details not known. As per her medical records, she was diagnosed to have viral encephalomeninger radiculopathy. Once she regained consciousness, she could not perceive any light in her left eye and was diagnosed to have optic neuritis. She was started on oral and topical medications and was discharged. On follow-up in ophthalmology OPD, she was found to have consistently high IOP and she was admitted for IOP monitoring and then was started on anti-glaucoma medication. Subsequent follow-up showed persistently high pressure and she was on a mix of multiple therapies and then left eye cyclocryotherapy was done for palliative relief. She started to notice on and off redness in her left eye following the surgery, which had no fixed pattern. Further follow-up again showed raised IOP in her left eye and was told about necessity of other surgery, and 3 months later she underwent AGV implantation and was discharged again on oral and topical steroids. Steroids were tapered over next follow-ups. She now comes with complaint of whitish discoloration of the black part of her left eye, which was noticed by bystander 6 months back, small pinnet sized, which is gradually increasing, and she visits us now for further evaluation and management. So no history of headache, no pain, for current episode, no history of headache, pain, redness, watering, backache, joint ache, skin lesion, recurrent blood transfusion, ocular trauma or similar complaint in other eye. No history of similar complaints in past. No, she is not a diabetic or hypertensive, not a known case of TB, asthma, cardiac disease and any other chronic medication. Coming to examination, she had 30 degree of exotropia in her left eye and facial symmetry is slightly asymmetrical with left side looking little shrinked. Extraocular movements were normal. Visual acuity was PL negative in her left eye and normal in her right eye. Dry retinoscopy showed no significant refractive error in right eye. And coming to the anterior segment diagram is very important for postgraduate. It has to be documented in each and every cases. This is the slit lamp picture. Right eye is almost normal. Left eye she is showing whitish discoloration in involving central, paracentral, and peripheral area with limbal vascularization, which is linear in pattern with some kind of looping, and also we can on the conjunctiva we can see the tube that is extruding from the anterior chamber via the sclera and in the subtenon space, probably the IMAT glaucoma valve that has failed. Right eye fundus shows a little bit of increase in CD ratio. CD ratio vertically is oval. It is 0.4 with slight inferior notching. Left eye, no fundus was visualized. Aplanation tonometry in right eye was 18 millimeter of mercury, and left eye was not recordable with aplanation. Digital tonometry showed T3 minus, that is a soft eye. Gonioscopy was with high level of pigmentation in right eye. Left eye gonioscopy was not possible. No significant visual defect in right eye. Axial length was reduced in left eye. It was around 18 mm. So diagnosis will be left eye phthisis bulbi with query band keratopathy and right eye glaucoma suspect. So the questions that usually are asked in the viva are, what is the relevant drug history for a glaucoma suspect, ma'am? So what should the PGs tell, which are the prominent glaucoma and the drug history that should be taken for a glaucoma patient?
So in this patient, see, the patient was getting recurrent episodes of loss of vision, vomiting and all that. So whether the patient was giving, whether, in darkness the pupil was dilating, it was an angle closure attack, and how the attack was getting relieved. And there are specific drugs like, the cost of the drug itself for glaucoma, the duration of the drug. The patient, always the doctor would have told the patient ki aapko kalia motia ya kuch hai. So, history itself tells you the diagnosis in many cases with regards to glaucoma and the type of glaucoma, because open angle glaucoma is symptomless and angle closure glaucoma is the one which presents with pain, that itself. Because open angle glaucoma patient would come at the late stage with loss of vision, which would be detected very late. Whereas an angle closure glaucoma is the patient where the patient has symptoms. So angle closure glaucoma is symptomatic, painful, and open angle is non-symptomatic. So these are various indications which may help you.
Basically, if you have seen this case presented, patient was there in the ICU. Before that, 7 years patient is complaining of diminution of vision. So that time there is no any detailed history, only vomiting and everything is happening. So we don't know what was that. When admitted in ICU, after that she was also diagnosed at the neuritis, and after neuritis she has been given the you can say steroids.
Yes.
And these steroids can be one of the cause of the glaucoma. But here if you see, it is one of the cause of the glaucoma. In the left eye it is a completely blind eye. In the right eye, yes, there is a, you can say 0.5, 0.6 CDR is there. So one thing is she may be a steroid responder, and this steroid responder persons can have the glaucoma, you can say, in the patient, and already there is a history of the steroid consumed when patient was in ICU. But see, relevance is not happening in the history. So that patient is a blind and having the episodes in 7 years. And after that there is another big episode which was general episode, and then the patient is blind by the left eye. So, and even in the angle now, left eye angle is not possible to see, but that history suggests patient may have the closed angle glaucoma, and that might have caused all these episodes. And these episodes there is no history of redness, only vomiting and everything history is there. But in the closed angle glaucoma there is also history of redness.
The initial history is giving the clue that it appears like a narrow angle glaucoma, wherein there is a sudden reduction in visual acuity, pain, headache, etc. I will agree with sir that there is some redness as well in these cases, and blurring with, as you said, in the history it was very clearly mentioned that there is some haziness, whitishness in the cornea as well. This means there was some edema in the cornea. So that is suggestive that it was a case of a narrow angle glaucoma. As far as the relevant drug history is concerned, again, steroid is something which is which can aggravate. But most of these are two mechanisms actually. You can have a mixed mechanism glaucoma as well, but there are two mechanisms. Most of the steroid responders, the angles are mostly open in these cases, and typically pigmentation as you showed.
Yes.
But you did not mention about the exact status of the angle. How much was the angle open? What was the
Yes.
degree of?
Yes, sir. I skipped through that, sir, because
Yeah, because in right eye it was visible.
yeah.
So we should also know about the angle
angle,
status.
yeah.
That will also give us an idea. But the history that was suggestive initially was, and the patient was not on any steroid earlier before the history.
Yes, sir. No, before on ICU admission she got topical.
No.
cortical.
First time when the patient had
No, sir.
no,
no
there,
history,
there was no history of
steroid
steroid.
intake.
So then it was not a case of steroid responder, rather it was a narrow angle glaucoma, typically presenting with blurring of vision, some haziness in the cornea, corneal edema, and pain, vomiting, headache. So that was typical of a narrow angle
Yes.
glaucoma.
So
Proceed for our
yes, sir.
answers.
So the relevant drug history, as it is told, most common is corticosteroid, systemic and topical, and then there are multiple other things that can aggravate angle closure glaucoma, like anticholinergic agent, topical atropine, cyclopentolate, tropicamide, or systemic antihistaminics, antipsychotics, anti-Parkinson's drug, and adrenergic agents also can induce similar angle closure attacks. So the next question will be, what are the clinical findings that warrant glaucoma investigations?
So the clinical findings will vary depending on whether it is an angle closure glaucoma or an open angle glaucoma. In an angle closure glaucoma, you will have iris atrophy, glaucum flecken, and say maybe an oval pupil. And in a say open angle glaucoma, because it is detected at a very late stage, there may be a sluggishly reacting pupil, and otherwise if it is a primary open angle glaucoma, then there will be nothing visible in the eye. So these are the things, like already the answers are.
In that eye is a hello. Yes. Hello.
This one is what?
In this, I think what you have written is correct. See what happens. You go behind your question. Now, what are the clinical finding that warrants the glaucoma investigation? Go next. See the clinical finding. You are very correct in the poorly reacting pupil. Yes, the relative afferent, the same. The pigmentation on the iris, the glaucoma flecum, smaller anterior capsular opacities, vertical enlargement of the disc, and the difference between the cup and tube,
Yes.
CDR, difference of CDR in the both eyes, that is also very important finding. May not be much more, but one is 0.3, other is 0.4. That can also definitely one of the, you can say, sign. Then the pupillary atrophy, yes, you can see in the closed angle glaucoma. The RNFL defects, yes, raised intraocular pressure, that is also this one. And also if you see these all clinical signs are there. Then in the symptoms also, delayed dark adaptation. If patient is having the delayed dark adaptation, that will also the one of the, you can say, the symptom that can help. So once you know these signs, another thing here remain, when you have seen all these things, then you can ask for the family history. Is there any family history in the this one that patient are carrying? That can also be added. So I think clinically you have written everything. In that we should also see that yes, in all these things there can be a glaucoma.
Yeah, I think everything is complete. Just one thing, maybe if it's the first attack of acute angle closure, and once the cornea clears up and you examine the disc, you may not have a large cup during that period. After multiple attacks, you get all
Yes.
that large cup. So that is something that may be variable. But even if it's not there, other things are there. One should investigate for the glaucoma.
For PGs, one thing is very much important. At least you check the shallow AC. If Either you can test it by torch or by Von Herrick's, whatever the thing available to you. Just go for the shallow AC is the most important among all the factors. So check for it.
And one of the most common question that is asked is what is the principle of aplanation tonometry? A theoretical question, but most commonly asked in Viva. So it is based on Imbert fixed law, where the pressure is equal to the force applied by the area applanated, and it has been now adjusted with CCT also.
Yes, very true. And one more thing that Dr. Rajesh Bhai said is very important is that the cupping will happen at a later stage. So it is only in chronic angle closure glaucoma that there will be cupping. Otherwise, in any angle closure glaucoma like acute angle closure and all that, there will be no cupping. So in a chronic angle closure glaucoma, there will be cupping, and in open angle glaucoma, there will be cupping. So to differentiate whether it is open angle or closed angle, you have to do a gonioscopy because the treatment will vary. In open angle glaucoma with cupping, the treatment will be medical, and in a closed angle glaucoma with cupping, because most of the angle is closed, then you have to see whether it is appositional closure or whether it is cynical closure, and the treatment is basically surgical. So even when there is a cup, you have to do gonioscopy or you have to do OCT angiography, anterior segment OCT, even advanced to see. But gonioscopy one must all know because the treatment is completely different for these two type of patients.
So the next questions are what are the factors that will be affecting IOP?
Already you have written that the factors affecting. In that you have written demographically age. Yes, definitely in age it affects the sex, race, heredity. You are correct. The systemic, you can say diurnal variation. Yes, very important that whenever you are taking the intraocular pressure, if you are taking at once, that is also diurnal is better. Seasonal variation, blood pressure. Yes, with it increases with the hypertension. Postural exercise, Valsalva, maneuver, and the ocular refractive error. Now here we'll have to write about the thickness of the cornea.
Yes, I meant the myopia will have.
But not myopia. You
and
get
hyperopia will have shallow AC.
You get keratoconus
Yes,
also.
sir.
You get hypermetropia also.
Yes, ma'am.
So you'll have to go for the corneal conditions, hai na?
Yes.
In the if there is a corneal opacity, then if there is a hypermetropia, it means cornea is thicker or cornea is thinner. So that definitely affects, and in that you'll have to change the, you can say, procedure by which you can say the technique by which you are measuring the intraocular pressure. So you'll have to add the corneal conditions here, and then the fluctuation is extraocular movements, eyelid movements, squeezing of the patient. Yes, all these things definitely add in the intraocular pressure. I think you are correct. You want to add anything?
Nilesh, that is the difference when we are thinking that, and what is in expert mind.
Expert
that
mind
is
says.
the session's target, that we are thinking that as a resident, that if we say refractive error, it indirectly or directly correlates with CCT or other thing. But examiners want solutions. You have shown number of demographic factors, but Professor Lane sir chosen only 4, 5, which is the key: age, hereditary, diurnal variation. So these are the things we have to know, and we only can know as long as we listen and being examined by some examiner.
I think CCT is a very, very important point which sir had
Yes, sir.
emphasized.
So then we'll come to what are the classical visual field defects in glaucoma. I'll just run through what it is and then we'll ask the experts. So the initial one is the paracentral scotoma that we get. It is on 30-2, and then we move on to 24-2 where we have nasal stepping, a dark, a more concentrated nasal stepping, and then we have an early arcuate defect, dark arcuate defect, and then a double arcuate sign. And once we have deep double arcuate sign, we don't have too much of points to be analyzed. Then we move to 10-2 where we can see the double arcuate sign, but some area is being now, we can see it is clear. Then that also goes off. Then we come to macular splitting. So, so anything else and any?
All things are there, but Rooney's nasal step is not there. Rooney's nasal step.
Yes,
And is very important because the Rooney's nasal step clinically it is important. See what happens, because the fibers which are there, they never cross the macula. So they are arcuate fibers are seen, and because of that you see the Ronis nasal step, and the I think the all others, the temporal small Iceland remaining, and the
Yeah.
you can say the tubular visual field, that can be also added.
Yes,
One
sir.
is the tubular visual
Visual
field,
field,
then the temporal small Iceland of
Yes,
this,
yes, sir.
and you can say Ronis this one, you can add in that.
Yes.
I think.
Thank you, sir.
Just one thing I would like to emphasize here is that sometimes you do get a disc which appears pale and maybe atrophic kind of, and you are having a field effect. It can be because of neurological cause, also it can be because of glaucoma. So in order to differentiate glaucoma from neurological cause by visual fields only, you should be knowing that the neurological cause respects the vertical line.
Yeah. Yes.
That is important.
Yeah. Very important point for VFA analysis, yes, sir.
You can present
The
second
retina
two,
case.
because Raki went for this.
Yes, sir. So, excuse me. Can we have the slides?
And one more thing, what you rightly said, Rajesh Bhai, is that the disc itself will give you an indicator, because it is said in glaucoma, even if it is a very, very small nasal rim, it will be pink. So if you have any pallor, then you must think that it is neurological, because if there is pallor, then there is a dual cause.
Thank you, ma'am. And coming to the next case, this will be a short image-based presentation. So, a color fundus photograph of the right eye showing the media is clear, there is no opacity, the disc is normal, the vessels show signs of neovascularization in the end of arcade. So we have to go stepwise, and then we have to come to macula. Macula is showing there are multiple small small hemorrhages that are suggestive of dot and blot hemorrhages. And in periphery RNFL, we can see there in inferior and superior area along with the hemorrhage we are seeing yellow area of ischemia suggestive of cotton wool spot, and in the superior temporal arcade the hemorrhages are showing a central area of clearing that are suggestive of Roth spots. So a diagnosis of diabetic retinopathy, severe NPDR, early PDR is made. Now the FFA of that same person was done, and we can see the FFA is showing a late stage of fundus fluorescein angiogram that shows area of leak from the area corresponding to the area of neovascularization that we have noticed in the color fundus photograph. Similar findings in the left eye also of the same person, and we can see there is an neovascularization of disc additional to all the findings that were present in the right eye, and we are seeing a small subhyaloid hemorrhage that is inferior to the disc, and while presenting we have to say how much away from the disc or away from macula it is. So it is half disc diameter below and half disc diameter temporal to the disc. So the finding, the fundus fluorescein angiogram shows corresponding finding with blocked fluorescence in the area of hemorrhage. So this is the periphery which shows area of capillary dropouts. So the questions that are commonly asked in the diabetic retinopathy case is what is the prevalence of retinopathy in cases of diabetes? So
See the answer what you have written here is can say the 1 in 25%, 5 years, 60% in 10 years, and 80% in the 15 years. See, basically, when there is a type 1 diabetes, in the type 1 diabetes, the retinopathy is much more than as compared to the type 2 diabetes. No, type 1 is more. Secondly, the type 1, you will see the blindness. If you see the blindness in the type 1 out of 4 person in type 1 are blind. 1 out of 4 person in type 1 are blind. If you compare with the type 2, 1 out of 10 person, it is blind in the, you can say, type 2. So type 1 is a blinding disorder that definitely gives, you can say, the very, very important thing, and what we consider today, the India is you can say here the diabetic retinopathy is much more. Here it is happening because of the, you can say, type 1 type of diabetes. And type 2, I think it is a on insulin, yes, it is much more in the insulin. Why? Because in the insulin, what is happening? It is the, you can say, once you give the insulin, that time, you can say it may be a slow release, or you can say it may be a short time, or you can say 24 hours. But that time, it is reducing the sugar. See, the diabetic retinopathy happens not because of the, you can say, more sugar. It happens because of the irregular sugar. It means the sugar which is 100 going 300, 400. If it remains at 160, 180, then you will not get much more type of diabetes. But because of insulin, to remain, now there is a 24/7 insulin has came, so that will see the sugar inside our body, and then it is injected. That is 24-hour sugar is maintained, whatever the number you can say you want. So that is more important than the giving insulin at 2 times or 3 times. Yes, oral hypoglycemic are the better than the insulin. But what happens? The people who are in the diabetes, they never consider their diet. And because they never consider their diet, then they eat the sugar, they eat everything. And I think the diabetologists also not giving much about this trace. They are not giving much trace. They, okay, you eat everything and you increase your dose. So that is problematic. So I think in the, can say in the oral hypoglycemia patient, reversal is possible only in type 2, not in type 1. And so what he has written is very true, that if it is a oral hypoglycemic agent you are taking, the chances of diabetes are late. But when you will have to also see SB1C. If your SB1C is constantly above 8, then the chances of diabetic retinopathy is much more if it is constantly below 8. So that is also an indicator that you will have to see. Now people are saying that that is not important, but yes, it is important statistically. So here we will have to also see that. So whenever you are maintaining the diabetes, the HB1C is also important. And I think what you have written is correct, in that only thing is that the, now we will have to add the constant monitoring of the insulin will definitely help to reduce the diabetic retinopathy.
One very valid point, sir, you raised, that is 24-hour control of blood sugar is important, because fluctuation in blood sugar can also result in breakage of plaques, and that can also be dangerous. So that is what is being emphasized these days,
Yes, sir.
in terms of constant control of blood sugar throughout 24 hours.
Yeah. So, ma'am.
There was a diabetologist who was speaking at a forum, and they have come up with a new thing, because we always consider HB1AC as our parameter, and they have said that that is completely wrong. Though we have no other parameters now, because HbA1c is the average. Like the sugar may be sometimes 50 and sometimes 350. So that is an average. So that itself is also not a correct indicator, because the patient has to be taught, like Lane sir said and Dr. Rajesh Bhai said, that that should be constant, because HbA1c, the patient may get misled into thinking which is the right indicator, which is again very wrong, because that is an average. But at present we have that the only indicator to check our patients.
Yes, ma'am. And we were studying one molecule, that is semaglutide. That is the first molecule that is said to have diabetic retinopathy prevention attached because of the constant blood sugar. So they are studying that, sir. So probably by 1-2 years, that should be the first thing that we should promote in diabetic patients.
And one thing important that now whatever most of those hypoglycemic drugs are having made in such a way that they maintain the normal blood sugar just to avoid the fluctuation what Professor Lame said. Obviously the second generation oral diabetics having a tendency to reduce the blood sugar much, but nowadays third generation hypoglycemics are made in such a way that they have to maintain a constant blood. So that there will be no hypoglycemia after taking the drugs.
Correct, Deepak. What Deepak is saying is the third generation drugs, they are coming in the market. Now they are examining, but there are some side effects. Those are happening on kidney. But definitely those drugs are more important. Another thing I want to stress, the people are taking the Ayurvedas and so many medicines. and then in that, I don't know what is the content in that. The diabetes is not controlled, then so many the Karela and non-Karela things are happening, and because of that, the diabetic their diabetes is not controlled, and they are not examining their sugar also. So because of that, the retinopathy is increasing. So we must tell our patient that yes, don't go for all these things. If you want, you can take an addition, but your this medicine should be there, so that will help you for prevention of the diabetic retinopathy and also the vision.
Thank you, sir. And the next question will be, it is again a theoretical question. What are the non-diabetic retinopathy related causes of visual loss in patients that have diabetes? And this was the list I could say, but I would like the expert opinion to be added, anything to be added in this list.
Yeah, you go to the question. What are the non-diabetic retinopathy related causes? Okay, go ahead now. So now amblyopia, ARMD, ischemic optic neuropathy, cataract, glaucoma, hypertensive retinopathy, retinal detachment, and then the other retinal pathologies. Yes, you have written other retinal pathologies, but here you can write ROP. Yes, in the ROP also you can get this. Acha, in diabetic you want, sorry, in diabetic I think then you are written.
Sir, like if
everything.
retinitis pigmentosa or something is there, other retinal pathologies.
Yes. You can write down but those are others.
Yes, sir.
Not in the diabetes.
Yes, sir.
But in the diabetes, yes, the patient is having the retinitis pigmentosa, that can also cause this, or you can say the macular pathologies in this diabetes can also cause. But everything is covered here.
I think the order needs to be changed.
Yes, sir.
The trauma and injury should not come up first, it
Yes,
should
sir.
come up last.
Last, yes, sir.
Like hypertensive retinopathy should come up, then retinal vein occlusion and ischemic optic neuropathy, then hyperviscosity syndrome, because in all these diabetics also there is risk of hyperviscosity, and if there is any further aggravation of hyperviscosity, that can also lead to occlusion and all sorts of things. And then comes your ARMD and glaucoma and retinal detachment and pathologies, whatever.
I kept this question, sir, because I was presenting my case in the final year, my final DNB exam, and my entire mind was I have to focus on diabetic, and suddenly this googly came, and I just froze. I was like, how to think, and then I started blabbering something, and so I thought that when we are presenting a case, still something other than that case can be tied to it and added and asked. Yes, sir.
Thank you, Nilesh.
So, what is the role of PRP in treatment of diabetic retinopathy? So, this is a theoretical question again. Laser is absorbed by RP and the underlying choroid, and for PRP typically a green laser is used, but other yellow laser and all is also being propagated. Thermal burns denature the tissue protein, which leads to local retinal cell death and coagulative necrosis. By destroying the largely unused or ischemic area, the VEGF production that is from that ischemic area is reduced, and the VEGF load comes down and reduces the neovascularization. So,
what you have written is correct. The PRP, yes, role of PRP is to reduce the neovascularization, also reduce the, you can say the intraocular, this apnavitreous hemorrhage or subretinal hemorrhage. So that reduces in PRP by doing the PRP. But what happens if PRP is not done at the time? See what happens, patient comes late, and because of that PRP may not be done, patient is having the vitreous hemorrhage, then patient has come to you. But another thing is, after doing PRP also, so there is a, you can say the overdoing of the PRP, sometimes you can get the burnout this retina. So this burnout retina is one of the complications which is happening in the PRP. So for that you will have to avoid and do it properly. So doing extra PRP also can cause the, you can say the blindness.
Yeah, that's true. The basic idea is that by PRP, by laser, you want to destroy the part of retina which is ischemic and requiring more and more oxygen, requiring more of growth factor. That's how the growth factor released. So you just want to destroy that and keep the oxygen supply enough for the remaining retina to function and That's the basic idea.
So the last question will be, what will be the role of anti-VEGF injection in management of PDR? NPDR and DME, it is commonly known. So
Now the when to inject anti-VEGF. So they say if it is a 350 micron, or you can say the edema is there, then you can go for the anti-VEGF. Now there are so many anti-VEGF in the market that we are saying that now this Hyla has came, then another has came, the another is coming. So many intraocular injections are coming. Basic thing here is how many intra-VEGF injections you are going to give to a patient. So any patient, maybe you can say the rich, or you can say poor, and then what happens, always this intravitreal injections, the patient will come to know how many injections you are going to give. I have seen the patient who has received more than 30 injections. So whenever you are thinking of the intravitreal injection, yes, it is needed, should be given 1 to 3 days before surgery. I think here I will not agree, not 3 to 4 days, but 7 days, minimum 7 days before surgery we should give intravitreal injection, and after that you can do. And 15 days within 1 month, once you give the injection, after 7 days till month, that 21 days you can go for the surgery. Then rebleed, and I can say definitely it prevent, but we don't know the duration, 1 month, 2 month, 3 month, how much duration it is going to prevent. And then once it is not preventing properly, say here basic thing required is, those patients are required into this anti-VEGF, they should be told properly that if you control your diabetes very properly, then the number of injection will definitely reduce. But if you will not control, so it is like an water which is there on the floor. Every time you will mop, again it will come, because excretion is defective there. And to avoid that, we are giving the injections. It is going to just absorb the water. So I think there you will have to again advise. And what you have written, only change that 7 days. But everything is correct.
Thank you, sir. Thank you so much, sir. Next, Ekagrita.
Thank you, Nilesh. Next presentation will be by Dr. Ekagrita.
Very good, Nilesh.
Dr. Ekagrita, just only short history and the questions. Okay, we have to finish session on time by 11th. What happens? Rakhi, your presentation is ready. So meanwhile, Ekagrita, you check from the AV team, and Rakhi will present his. Rakhi, just small history and only questions.
So I'll be presenting a case on lens. So this is a 65-year-old gentleman who presented with gradual onset defective vision in both eye and some glare issues. His IOP was 22 millimeters of mercury in both eye. Best corrected visual acuity was 20/80 N12 right eye, 20/60 N10 left eye. So my first question is, what is the diagnosis and what is the content of the deposited material?
Cataract with pseudo exfoliation.
So it is a case of pseudoexfoliation, and the deposits are actually elastin fibers, mainly containing fibril and alpha elastin. So the second question is how to differentiate it from true pseudoexfoliation. So the true
In true exfoliation, you get a scroll of of the delamination of the layer of the capsule, and you don't get those fibrillar material mainly deposited at the pupillary rough. In pseudo exfoliation, you don't get that kind of a scroll, and you just get fibrillar material deposited on the pupillary rough, and that gives you an idea that.
yes, sir.
Basic is true is complete and false is incomplete.
And second,
Keep
you
in
can
mind
ask even in the history, although that in those who are working in a heat condition or oil factory,
Glass bowlers.
they having usually true, but pseudo exfoliation is not.
Third question is name 2 other sites of deposition of this material and the related ocular features. So,
Trabecular meshwork.
so it can be deposited in the trabecular meshwork causing glaucoma. It can be in the sonules causing sonular weakness and dialysis. It can be in the pupillary margin causing a small and rigid pupil. And next question is the gene which is associated with pseudoexfoliation syndrome. It is the LOX-L1 gene.
This is a just now they have come with one gene, and they find out this, but it is seen only in the if you see the 100 cases of pseudoexfoliation, out of that they are saying that 7% of the cases may have this gene. So others is they are saying, but yes, one of the like glaucoma, there is one gene now causing the pseudoexfoliation. But what they say here also, basically it is a temperature where the patient is working, and that causes the pseudoexfoliation.
Question number 5. What are the complications that need to be expected in cataract surgery while performing such cases?
Now in such cases, the basic complication in cataract surgery is, as you to see the pseudoexfoliation, there are also the zonular weaknesses. The zonular weakness is there, non-dilating pupil is there, and in such situation, the cataract is always, you can say, the harder, because it has happened because of the, you can say, the temperature. And so because of that, what happens in such situation, it is better to go for SICS. You should not go for picomultiplication. You have written chances of IOL drop and VR surgeon nearby. It is not required if you go for the SICS. And all modern people should think on the SICS when there is a pseudoexfoliation. Another thing is, in the pseudoexfoliation, you operate the patient early where the zonules are not weak. It means if patient is having the stage 1 or stage 2 cataract, you go and operate. If the patient is coming late, then the SIC is better. Now you can use the, you can say, the pupillary, you can expanders, or also you can use the capsular support, and in that, but always better to go for the SICS, and if possible you can go with the PICO, but chances of the subluxation or dislocations are much more. And as you know, it is pseudoexfoliation. It is always end in complication. To avoid, experience will help.
So how to manage if there is intraoperative sonular dialysis?
See, the zonular dialysis is there only when there is a pseudoexfoliation and true pseudoexfoliation. If it is a not true pseudoexfoliation, then there is no zonular dialysis. In pseudoexfoliation, there is always a zonular dialysis, our weakness. Without that, there is no cataract. So if it is there, then as you see, seen this, all these rings and CTR and all other things, definitely that will help, but not in much in pseudoexfoliation. Where the other zonules are stronger, then that will help. Now what we are doing, by putting these 3-4 clock rings or all others, we are taking the support of other zonules. But here, the other zonules are also weak. So it is always better that we must use the, expanders like that, remove the nucleus, and this always go for CTR. Why? This CTR will support in 360 degree. CTR will be better than the local segment. So you can go for the CTR.
And what are the chances of development of glaucoma in such eyes?
See, it is said that in the pseudoexplanation, 12% more glaucoma is developed as compared to the non-pseudoexplanation. Secondary glaucoma chances are much more in these cases. Now here the high around 40, 45-50% chances, yes, it may be there. But in the glaucoma, if you go to the glaucoma, it is 12% pseudoexplanation is the cause in the 100 out of 100. So in this case, yes, 45 to 50 in pseudoexplanation cases it may be there. And here the see the treatment here, as you know, the pupil is very this one, there is a pupillary block is happening, and also the you can say the pseudoexpression also is in the angle. So in this the trabeculectomy definitely work than any other surgery.
Thank you, Dr. Rakhi.
Thank you and congratulations. Very good questions.
Dr. Ekagrita.
Very good. I think this exercise that definitely gives the insight to the student also.
So this was a case of a 17-year-old male presenting with complaints of watering, foreign body sensation, sensitivity to light, and pain for 5 to 7 days. What can be the positive associated history?
Well, if you're seeing such a patient, you don't have to think anything else apart from herpetic epithelial keratitis. And associated history can be, you have written about the eye pain, redness, photophobia, blurring. So any ulcer, any keratitis will have RSVP, redness, sensitivity to pain, sensitivity to light, that is photophobia, then vision loss and pain. So RSVP you should remember. And then of course, history of contact lens use can be there, but it doesn't directly relate to the occurrence of viral keratitis. It is basically because of the reactivation of the herpes virus that is present in the ganglion. And yes, previous episodes of keratitis can be there because viral keratitis can be recurrent. And the use of topical or systemic steroid doesn't have a role in viral keratitis. It can have a role in fungal keratitis, particularly if there is some abrasion there and you have used topical steroid, then one can have, because the local immunity reduces and then you can have infection by the fungus. Then oral or nasal, so otherwise the patient will have typically complain that he had a viral infection. He had URI, fever, running nose, etc. And then coming with these. So many times these are associated.
Now the most important thing is what actually is there in these patients is very shocking that there is a lesion, there is a stain like this, and there is keratitis, but the patient does not complain of any pain. And this is something which marks you towards the herpetic condition, because in this herpes, because there is loss of sensation in spite of such a big lesion, that the pain is absent. What you actually find is a preauricular node. So that marks you even before the stain towards a herpetic lesion, because the absence of pain. Otherwise, even a small foreign body causes so much pain and photophobia. So this is the first thing that should put your antennae up, even if you are in a field where you have only a torch and no possibility of a stain, that this is viral with the associated features.
Very important point, because there are a few patients that have come to me with history of just redness in the eye. And the patient was being treated as conjunctivitis, and now the patient came that he is not resolving, and then I saw the patient on slit lamp and put a fluorescein, and it was classical dendritic
Next
keratitis.
question.
The conjunctivitis, patient is having conjunctivitis and non-diagnosed cornea, okay, I agree. But conjunctivitis, then they give steroid. And when they give steroid, then there is a mess. So I think in conjunctivitis, whenever we are using steroid, we must take cautions. We must ask cornea person to intervene.
Next question.
What will be the effect on the corneal sensitivity, and what instrument will be used to measure that? It's typically corneal sensation.
Cotton wisp to. What is most important that when you are examining these patients, don't bring the cotton wisp from the front, bring it from the sides. Otherwise, the moment you bring close to the patient will blink. That is the correct way is to bring it from the sides and ask the patient to look straight ahead.
What are the pattern of presentation of the given etiology? Depends on the primary infection or the recurrence.
It's most likely.
Symptoms and
also.
signs.
Mostly is in very early childhood, infancy, and then all these dendritic keratitis they come as a recurrent viral keratitis, because the virus is already there in the ganglia.
There might be corneal stromal disease, central corneal edema, KPs, Descemet folds, Weasley immune ring, elevated IOP, neurotrophic ulceration, non-healing epithelial defects, and other signs like vesicles on eyelids and skin, or uveitis or retinitis.
Yes. So one tip that I would like to give over here is, whenever you are thinking of any disease or anything, and you don't know everything. I mean, you don't know. You think you might forget during the exam. So always go anterior to posterior, like nasal sores, vesicle on the lids, then cornea, epithelium, stroma, that is say scarring, then endothelium, endothelitis, involvement of the iris or geographic. So if you go from anterior to posterior and then think about all the layers, then it will be easy to remember all the disease patterns that occur, like say herpetic keratitis, which is anterior, then stromal, then dendritic ulcer, then endothelitis. So that way you will not forget any time to write this. So that is,
Yes.
I always advise that this is the easiest way to do it.
Very true.
What do you expect the anterior chamber findings associated with this condition?
Mostly you have anterior chamber reaction. That's what you get.
In case of endothelitis, it's can be based on the area of involvement.
So yeah.
Next question.
What are the treatment protocol for viral keratitis in different presentations? It depends.
Remember that if it's epithelial keratitis, you have to use topical acyclovir. If it's stromal or an endothelial keratitis, you have to use systemic acyclovir along with the topical steroid, so that the inflammatory signs, the immune, the actions that have taken place in the form of edema of corneal stroma, in various forms, like in disciform keratitis, you get a round disciform kind of an appearance. In endotheliitis and trabeculitis, you get whole descemet folds and all that, whole of cornea getting edematous. So in these cases, you give systemic acyclovir and topical steroid.
What does HEDS trial recommend? So it was a herpetic eye disease study which established treatment strategy for immune stromal keratitis, which included topical steroid to shorten the disease course and systemic antivirals to decrease the frequency of recurrence. It's arranged in the form of questions and findings.
Basically, what happens most of the time, examiners just ask whether you know for this trial or not, and what you have just concluded, that which of the disease it reduces the course of the disease. That is the most important question usually examiners would like to know. No one wish to know that you remember all these questions, findings and references, but what is the final conclusion or the outcome of this trial is important for the PGs. Next.
What should be the prophylaxis in a patient getting penetrating keratoplasty with a known history of herpetic keratitis?
Prophylaxis for you give acyclovir 400 mg twice a day for 6 months to 1 year, or you give other drugs like valsiclovir 500 mg once a day for again 6 months to prevent recurrence of it.
So we finished all the talks and completed on time, sir. We request all one to have a group photograph. That's
for inviting us. Thank you, Professor, Dr. Lane sir, Dr. Rajesh bhai, for the wonderful inputs, and thank you the presenters and everybody present here.